Hello and welcome, RSN Networkers, to the second installment of our online workshop series. With us today, we've got Dr. Ben Gaunt from Zithulele Hospital in the Eastern Cape to tell us all about treating a nation. Dr. Gaunt will be discussing how focusing on the core values of rural health care allows for a massive improvement in the lives of many who have been historically neglected. It is academic and intellectual challenge that brings great meaning into the lives of the people in a community and to the healthcare workers themselves. He then goes on to discuss the excellent HIV treatment program with a high ARV delivery rate to patients' homes as soon as ARVs were available in South Africa. He takes us on a journey of this program from its early inception when HIV medication was difficult to obtain until now. Zithulele took an integrative approach that was cognizant of the realities facing their community and then formed part of an advisory committee on central chronic medicine dispensing and distribution, which aimed to distribute HIV, TB, and non communicable disease medication to patients' homes on a national level. More than anything, this talk aims to challenge us to become innovative agents of change within our own communities. Enjoy.
Well, hello, and welcome to this short talk, which be nice to contribute to the Rural Student Network and their new YouTube channel. My name is Ben Gaunt. I'm the clinical manager at Zithulele Hospital, which is a rural hospital in the old Transkei part of the Eastern Cape, and I've been here since 2005, so just coming up for 15 years. Been asked to share a few thoughts on what constitutes quality rural care and why rural healthcare needs to be a focus at all, and particularly to share one of the stories from a few years ago now that has really informed how we've gone about building the health services that we have here. It's hard to encapsulate it into one talk, and I don't necessarily want to suggest that we have a formula or any easy solutions, but I think that what I hope to do is just to stimulate the idea that rural health really doesn't have to be second best. There tends to be a sense sometimes that urban facilities offer the best possible care, and that rural is by definition something not quite as good. And so countering that perception has been a particular passion of mine and my wife's and the colleagues who I work with. So just to share some of those thoughts with you. It's hard to know where to start, but I think, in a cliched kind of way, we often start with vision. And for my wife and myself, coming to Zithulele was about responding to a call, which we felt was part of our faith, to come and build or rebuild a rural hospital, and to really show God's love to people by the way that we did that. And so I think from the beginning we've tried to have the focus on something other than ourselves. It's very easy, even in the public sector, to sometimes get caught up in the fact that it's your job and your salary and your life that you're living. But one of the advantages of rural is that you're surrounded by people who've had very little access to the kind of opportunities that those of us who've been to medical school at least have had access to, and that really is irrespective of where you've grown up and what your family's financial status might be. The reality is that we as doctors have something to give back, so we've tried to approach rural health from that perspective. And so from an institutional point of view, our vision has really been to be and become a centre of excellence, an example of what is possible in rural care, and to also be the kind of place that people want to come and work, because we think they go hand in hand. We want to be the kind of hospital where people want to come and get healthcare, and we want to be the kind of hospital where people want to come and give healthcare. Those two become a virtuous cycle if you get it right. Some of the things that we found helpful and come back to time and time again are our core values. It sounds soft and a little bit fuzzy. Maybe it's the softer side of medicine that sometimes puts people off when you're all excited about physiology and anatomy. But the reality is that they distill the essence of who we are and what we're doing here. And I I think that they've informed our care almost more than anything else. So I want to share those with you as a way of getting into this topic. I think the first one is the most important, and it's prioritizing patient care. And we're going to come back to this as I share the example that I have for you this evening. But the reality is that the system at times can feel so overwhelmed. You, as a healthcare professional, can feel so overwhelmed that your patients become like sausages in a sausage factory, people or things that you're trying to process, organs or diseases that you're trying to treat. Um, and equally, there are many other things competing for your attention. You'd be surprised how many meetings and trainings and workshops and audits and other things we get invited to or compelled to attend at times. And making sure that we're always pulling back to the number one thing that brought us here in the first place, patient care, is super, super important. So we really try to make our decisions and our priorities around the people who we're here for in the first place. Our second core value is multidisciplinary teamwork, and we've really found over the years that working together in a team of professionals that encompasses people from a variety of disciplines adds value both to the patient outcome and also to your professional experience. Importantly, I think we often overlook the degree to which we've been socialized by our professions and the different perspectives and worldviews that we carry into patient care, depending on the perspective that we've been trained in. And so having a bunch of different viewpoints discussing the same patient really adds value, and there's an exciting way to practice medicine as well. So that teamwork really helps, and perhaps all the more so in a rural area where you often feel isolated. If you're together doing something together with other people who share similar passions, profession-wise, it makes a massive difference. The third one is respect for relationships. I think that's important because sometimes developing systems of care and having different points of view can lead to conflict. And the reality is that we are all human, and we're going to have times when we're disappointed in each other, times when we really rub up against each other the wrong way. And when you're speaking up for rural, that can be especially true. So trying to learn how to do that in a respectful way is super, super important. And I think also in rural health, the reality is that relationships are important. Rural people are remarkably connected in a way that I think often urbanization has stolen from us as humanity. And so remembering that we're people at the end of the day and trying to connect in that way, it's important. Our fourth core value is quality care, and this one's close to my heart and obviously links into the clinical example I want to bring. But again, it goes back to what I said right at the beginning, that rural doesn't have to be second best. You don't have to dumb down your knowledge or fall behind with being up to date with the latest guidelines. In fact, quite the opposite is true. You need to be on the cutting edge of what's happening if you want to provide the best care to your patients, because it's not going to be somebody else coming to bring it to them. It's you. And so the question is simply, is this good enough for me? And I've often found that a particularly helpful aid to decision making as well. What would I do if this were my wife or my sister, a family member sitting in front of me or being examined in the bed? Or do I need to transfer them? Do I need to do a Caesar? What drug combination is the best? It's very more clearly distilled when you are able to think of it through the lens of, is this good enough for me? And so that really has become one of our passions, and again informed our ALV program in particular in its early days. The fifth one is continual learning, and obviously that goes very closely with quality care because the world changes fast. We're living in a time of coronavirus. None of us knew that just 6 months ago. So the reality is we've had to learn. And if we want to stay up to date with what's what, you have to keep reading and stay connected. And the same is true of pretty much any discipline. And I think one of the thrills of rural healthcare is that you really are trying to be a generalist in the true sense of the word. You need to be able to cope with whatever comes in the door and function at a pretty high level within every discipline. So there's a percentage that you're not going to know. And I often say, we need to be comfortable in the 80% of everything. The other 20% we can defer or ask advice or, know where to look it up. But 80% of everything's quite a lot. And so you've got to take an attitude of learning into life, and you can never stop learning, I think. I once heard somebody say, "Oh, I'm old now, don't try to teach me anything new." And I guess that sounds as an alarm bell and a reminder to me not to become like that. And that's my challenge to you as you maybe set out on your career. Make sure you take an attitude of learning into it with you. The last core value, which I also want to share because I think it's crucially important, is a hopeful attitude. It can be so easy to become cynical and downhearted. And in the private sector, you can look across at the public sector and think, gosh, the private sector has its own troubles. I've never worked in the private sector, but what I observed in 12 months in New Zealand was that with one of the best healthcare systems in the world, it's still easy and possible to complain. And so taking the opposite attitude, that you can actually find something good in the system and also be hopeful about the future and your ability to play a part in improving it, makes a massive difference to the day-to-day, not just survival but thriving. So those core values are shared with you really because I want, because I believe that they underpin so much of what we do, but because as I think back on the last 15 years and as I think forward to the years still to come, I think that when one examines what's happened through the lens of those things, there's a lot of understanding and learning in them. So I particularly want to share a story about our ARV program. And it's a long story. I'm not going to bore you with the blow-by-blow account of how it developed, but I think it has some important lessons for rural. And so once upon a time, actually, unfortunately, our leaders didn't believe that HIV caused AIDS, and that obviously had a huge effect on our country and on our communities, on people's individual lives. And I think for those of us who practiced in that era, the memories of telling people that there was no hope, that they tested HIV positive and that they were going to die, seeing people in casualty who were presenting with PCP pneumonia or another opportunistic infection meant that they had literally weeks or months to live. Our pediatric ward in the hospital I worked at the time had a single wall with wall oxygen available, and that's where all the babies lined up with PCP pneumonia. We used to call it death row. So I think remembering that and knowing where we've come from informed a lot of what we took into our HIV program with us. And I think also even now, nearly 15 years later, it's easy to forget how far we've come. But in the same way as with other kind of human rights abuses, I suppose, we should say, let's not forget the lessons from that time. Let's never forget our history, and let's never forget the trauma that it caused and the unnecessary pain and suffering. And hopefully let us also use the lessons so that we can build a stronger health service and a stronger society. So that sounds really dramatic, but I think it's, when I think back on that era, it was a profound experience. That meant that when we were at last able to access ARVs, we really wanted to do it properly. In the early days of the ARV rollout, you had to jump through a million hoops before you could get accreditation to prescribe ARVs. You had to have all sorts of things in place and run support groups and counseling and have this sort of paperwork and that sort of staffing, and then after an inspection or two, you were granted the permission to prescribe life-saving medication. It almost sounds bizarre now, but that's how it was. And so we took that responsibility pretty seriously. In fact, before we were accredited, our neighboring hospital, Madweleni, had received their accreditation. And so we used to take our patients across there once a week in a hospital vehicle to access ARVs. Those first couple of patients who'd put their hand up and jumped through the hoops. A stigma was huge. It's really incredible when you think back, but when we started out, people used to have HIV tests, and the result would often be written on a tiny scrap of paper that the patient would hide away, and they'd come back into your consulting room, and you were like, "So did you go for the HIV test? Because there's nothing written in the book." And then they'd say, like, "Yeah," and they'd like fish out the little piece of paper, and you'd kind of have to go like, "Oh, what does that say? Oh, non-reactive. Oh, well, that's good news." Or reactive. Okay, what did they tell you? There was a lot of stigma and a lot of fear. And I think also a real sense of uncertainty as to what the future held. So we wanted to go in it saying, well, let's do this properly. These are people who've been waiting for ARVs. We've been fighting as a country to get ARVs to our communities, and here they are. I mean, medically, we knew nothing. When I was at med school, we didn't have ARVs, and we weren't taught much about HIV. And the truth of the matter is, even a couple of years later, coming to Zithulele, we hadn't had much exposure to it because it hadn't been a government priority. So we had to learn quickly. We went on courses, and again, there's core value number 5, the continual learning part. It wasn't saying, well, I don't know anything about HIV. It was like, oh my goodness, I better find out fast and get my head around some of these concepts that are initially quite complicated. So having done that, we realized, whoa, okay, in those days, again, your drug options were limited. And so you really wanted to get it right first time. And we were influenced, of course, by the mindset that was very pro adherence above everything else. And I think that slowly changed towards accessibility being even more of a priority, which kind of makes sense. But the point is, we did it properly. And when we realized that the lack of availability of ARVs at our clinics and the more peripheral sites to the hospital was actually impeding people's ability to get onto life-saving medication, we realized we needed to actually get medication out there. And in those days, that was also a little bit political and complicated. Clinics weren't accredited for ARVs, and they didn't have the staffing. They didn't have the drug supplies. So we designed a system that allowed us to take patients' medication out to them on a named patient basis. We felt it was important that if we're taking ARVs out there, we wanted to have the right drug for the right patient at the right place and time. And that program eventually grew with the help of NGO support through the Donald Woods Foundation and later Jabulani Rural Health Foundation, to a program that had more than 6,000 patients on it. And that didn't include all of the patients, because some of the community health centers and others were getting on their feet to the extent that they'd started patients separate from the program as well. But we were delivering medication with an accuracy rate that was probably above 98% or 99% in terms of correct scripts, drugs, etc., etc. But excitingly, when we audited it back in 2014, we had something like 92% of our patients had their blood test done on time, and 94% of them were adherent and suppressed on first-line treatment. And that was in an extremely rural part of the province and a district that traditionally forms sort of the rear guard of districts in South Africa when you rate us on performance. So it showed what is possible, and I think we did that through a tremendous team effort and emphasis on creative thinking and trying to get things right. Really saying, yeah, we know that policy says this, but policy doesn't always let us get the right drug to the right patient, and it's more important at the end of the day that this person has medicine to take to suppress the HIV. Like I said, it's a very long story, and it held quite a lot of angst. There were a number of fights over policy, and frustratingly, we never strayed outside of what was mandated by national government. But every manager along the way kind of interpreted policy in their own way. And, we once had somebody say to us, "What is so complicated about HIV? Why do you complicate it so much? Why don't you just put the drugs in the cupboard and take the patient, open the cupboard, and give them the drugs?" And we were like, "Yeah, well, it's a little bit more complicated than that. We didn't want people dying of side effects. In those days, D4T caused a whole bunch of things that could kill you. And there are side effects even today. So whether it was side effects or whether it was drug choice or whether it was viral load monitoring, we wanted to do it properly. And we wanted to approach it from a perspective that wasn't just about one of those things. And I think that's another advantage of rural, actually, that you integrate your systems. You're not just a clinician with somebody else responsible for drug supply. You're not just a pharmacist divorced from the clinical realities. You're not just a manager responsible for trying to set up systems and get them to function. You're often, if not playing more than one role at a time, you're closely connected in and realizing that there's so much more to this, but equally so much more opportunity. So we ended up being part of the kind of advisory large group of advisors on the CCMDD rollout, and they didn't listen to all of our examples, but I think the message in that and in many other things subsequently and is that it's possible to be excellent. It's possible to really do things well. CCMDD, funnily enough, has varied success. There's some parts of the country that do it brilliantly, but we have clinics where the viral load compliance rate in terms of the actual test being done is as low as 20%. We don't know whether people are suppressed or not. I mean, the suppression rates the labs are reporting is still pretty good, so we hope that it's okay, but it feels a little bit like it's more left to chance. And of course, that's the challenge. We've got so many more people on ARVs, we've got so many other competing priorities, and we've still got a relatively small team. So the challenge becomes, how do you integrate these competing priorities? Of course, as a rural clinician, you're well placed to be able to understand their various levels of importance and, of course, importance to the patient as well. If you're a disabled person living down in a valley, that's a pretty significant reality, and our rehab team need to get onto that, and you need to work out systems that are going to help improve the quality of life for somebody with disabilities. And so that comes up in importance in a way that perhaps gets overlooked a bit in the cities. Likewise, from a health point of view, we focus on the big four: HIV, TB, maternal health, and child health. And we did that from a purely practical point of view. It's not that we don't like treating other diseases. We certainly will treat whoever walks in the door. But the truth of the matter is those were the four things where we had to get systems right to start with. Rural healthcare is an incredible journey. It's an adventure, really. And often, in fact, to be honest, when we started out, we didn't have a clue. It feels like, looking back, we just wanted to do our best for the patients and really try and give them hope by being here, by being committed to staying. The sticky core of the four of us, Carl and Sally LaRue, and my wife Taryn and myself, who committed to being here for 10 years to start with, has really enabled growth to happen around us and for other people to come and become part of the dream. And I think it's all those things together. We often come back to the core values, and I hope you saw some of them being echoed in the story that I told. There's so much that one can share about the different realities of rural. But I think most importantly, it's about people caring for people, and you get to really do that in a rural place. So, yeah, it's not second best. It might be far away from the city. It might be something completely different to the environment in which you trained. I grew up in Cape Town, but it provides opportunities um, for incredible fulfillment, making a real difference to people's lives. It's academically and intellectually stimulating, and I think when you approach it from that point of view, when you say, this is what I want to be part of, it can be. I mean, frankly, it's more of a blessing than it is a burden by a long shot. I have a wonderful life. We have a wonderful family life here, and we get to be part of something that's bigger than ourselves. And ultimately, I think that's the kind of thing that brings meaning um, in life. And it's so easy to lose track or focus on that, get onto the hamster treadmill of life. Um, so, yeah, still 40% of our country or more live rurally. There are many, many challenges. Of course, there are urban challenges, very different ones sometimes. Um, but rural people have historically been neglected. Um, and for us, it's an incredible privilege to give back. I hope that this maybe sparked some thoughts or challenged you in some way to think about how you can use your skills and career to give back to others and to be part of building our country into a better country where everyone has equal opportunity and access to healthcare, something that is close to our hearts. Please feel free to get in touch. I would encourage you to uh, look through some of the other stuff RSN are putting up on YouTube. There are going to be stories of electives and people's experiences of rural, perhaps more talks from other rural doctors. We'd really encourage you to connect with us because we are passionate about sharing our love for what we do. Thanks so much for listening. Good night.